Our case study is on a 42-year-old male who presented with polyuria, excessive thirst, blurry vision, dizziness, fatigue, and numbness in his feet. A set of OBS was taken upon admission, and his BP was 144 on 96. His heart rate was 82 and had a rest rate of 18 and a temperature of 37.2. His height is 170 centimetres and weight 110 kilos. His BMI worked out to be 38.1, which puts him in the obese category. We did a random BGL test on him, and he was 14 millimoles a litre. He's a smoker and eats mainly takeaway food and has a fast food diet. He does have a desk job as an accountant, but hardly does any exercise. He was diagnosed as hypoglycemic upon admission, and his HbA1c blood test showed his glucose levels at 8%. A random BGL was taken, and he was 14 millimoles a litre. If on fasting it's over 11.1 millimoles a litre, he will be diagnosed as diabetic, which it was, and he is now a type 2 diabetic.
Metabolic disorder characterized by chronic hyperglycemia with disturbances in carbohydrate, fat, and protein metabolism, resulting from defects in insulin secretion, insulin action, or both.
Diabetes is the fastest growing chronic condition in Australia, and it is the major health problem in 21st century. 280 Australians develop diabetes every day. That is almost like one person in every 5 minutes. 1.7 million people live with diabetes, and it costs $14.6 billion to the Australian economy. So, as nurses, it is very important to help people with diabetes to manage their diabetes and to improve their quality of life.
Type 2 diabetes belongs to a heterogeneous group of disorders, CRISP and Taylor 2013. It is characterized by decreased liver, muscle, and adipose tissue sensitivity to insulin, and a defect in insulin secretion from the pancreatic beta cells. It results from decreased insulin production by the pancreas and increased insulin resistance, which is characterized by an inability to use insulin effectively or a reduction in insulin secretion. Diagnosis of type 2 diabetes is made when both insulin resistance and a reduction in insulin secretion are present, Osborne and Ra 2014. The development of type 2 diabetes follows an evolving course which can be divided into 3 different stages as follows. In stage 1, genetic factors influence both insulin sensitivity and insulin secretion. There is an initial period of hyperinsulinemia, a condition in which there are excess levels of insulin circulating in the blood relative to the level of glucose. During this period, the pancreatic beta cells are able to overcome insulin resistance. Even though there is an underlying defect in insulin secretion, the pancreatic beta cells are able to produce high levels of insulin and maintain normal glucose tolerance. In stage 2, which is also a compensatory period, insulin resistance continues to increase, and the compensatory hyperinsulinemia becomes insufficient to maintain normal glucose homeostasis. Under the condition of insulin resistance, visceral adipose tissue is very sensitive to the effect of catecholamine, a class of aromatic amines which includes a number of neurotransmitters such as adrenaline and dopamine. And insulin resistance is associated with enhanced lipolysis, which is breakdown of fats and other lipids by hydrolysis to release fatty acids. This leads to increased free fatty acid production and mobilization, exacerbating insulin resistance in liver and muscle tissue. and impairments in insulin-mediated glucose uptake, particularly in muscle tissue, becomes evident. Farrow and Dempsey, 2014. And also, insulin-mediated glucose transport into skeletal muscle, which is the major target for glucose disposal, becomes impaired. Fasting plasma glucose levels remain normal, but postprandial after meal plasma glucose levels will rise. Finally, in this stage, physiological stress that increases the production of hormones such as catecholamine, cortisol, growth hormones, and glucagon will cause hyperglycemia. In stage 3, which is the final stage, there is a further increase in insulin resistance. The restraining effects of insulin on hepatic glucose production becomes impaired and plasma glucose levels increase. In addition, the worsening hyperglycemia has toxic effect on the pancreatic beta cells, and insulin secretion subsequently declines slowly over many years. With increasing insulin resistance, there is an even greater increase in free fatty acid production and mobilization, which causes a further increase in insulin resistance. Fasting and postprandial hyperglycemia result from increased insulin resistance and restrained hepatic glucose production and glucose toxicity. Farrow and Dempsey, 2014.
Diagnosed type 2 diabetics can initially control their diabetes by change of diet and exercise. If this change is not effective within 2 to 3 months and glycemic targets are not reached, they will have to be prescribed antihyperglycemics. Antihyperglycemics used to bring down blood sugar levels to keep them at a stable level. There are 6 classes of oral medication and 2 classes of injectables used in Australia for lowering blood glucose levels. The main medication that is relevant to the patient is metformin. Metformin is given when a change in diet and exercise is not enough to aid in the reduction of glucose in the blood. Metformin works by reducing the amount of insulin released by the liver, as well as increasing the intake of glucose that is absorbed into the body's cells. The side effects of this drug include nausea, vomiting, bloating. Sometimes metformin may not be sufficient for the patient with type 2 diabetes mellitus, and they may have to combine different hypoglycemic medications. In Australia, there are 4 set combinations that can be used. These include glibenclamide, rosiglitazone, sitagliptin, and vitagliptin. Glibenclamide. Glibenclamide is used to stimulate the pancreas to release more insulin, bringing down blood glucose levels. This combination of tablets must be taken before food, as it can cause hypoglycemia. Side effects of this can include weight gain and rashes, and should not be taken by pregnant or breastfeeding women. Rosiglitazone enhances the effect of the body's own insulin and lowers blood glucose levels in this way. This drug, however, takes months for it to have full effect. The benefits of rosiglitazone is that it does not cause low blood glucose levels and works well with metformin. Side effects of this drug include weight gain and fluid retention. It should not be taken by those with heart failure, liver disease, or by pregnant or breastfeeding women. Regular liver function tests must be done when taking this drug, as it can have effects on the liver. Sitagliptin works in 2 ways to reduce the blood glucose levels. It increases the amount of insulin released by the body, as well as decreasing the amount of glucose created by the body. Insulin. Insulin is a last resort medication for those with diabetes. It is used when the body's insulin is not effective enough, or the body's natural insulin cannot make enough to stabilize blood glucose levels. The insulin provided will stabilize this essential balance needed. Lifestyle changes and tablets may only delay the need for insulin, as when insulin is required, it is due to the natural progression of the disease. Blood glucose levels must always be taken before giving insulin, as it is given via subcut injection, usually into the fatty tissue in the stomach. It reacts quite fast and lowers the blood glucose levels. If BGLs are not checked, or if they are below 4 millimoles a litre, you could have hypoglycemia. Do not administer if BGLs are below 4 millimoles. millimoles a litre. If BGLs are lower than that, a glass of orange juice, a sandwich, or something sugary must be consumed and BGLs retested before administering insulin. We must also remember our NSQHS standards and make sure we follow the 7 rights of drug administration and dispose of our sharps and blood products in a safe manner.
The management of patients with diabetes whilst in hospital is often challenging and requires a coordinated, multidisciplinary approach. The monitoring of blood glucose is extremely important for patients with diabetes. Blood glucose is monitored by bedside monitoring and adjusted through pharmacological management in a hospital setting. The goal is to keep Bob's fasting blood sugar at 3.89 to 6.67 millimoles per liter and the postprandial blood glucose level at 7.78 millimoles per liter. Glucose monitoring is critical to pattern control. Teaching Bob blood glucose monitoring will increase his independence and flexibility of lifestyle. We should educate him about when blood glucose level needs to be checked, how to record them, and how to adjust insulin levels if necessary. We need to manage Bob's hypertension to prevent further complications relating to his diabetes. In a hospital setting, pharmacological management is optimal in the reduction of hypertension. The aim is to empower Bob to become the problem solver and decision maker in his own condition. Medication adherence is essential in controlling diabetes. We need to make sure Bob understands the proper use of prescribed medicine and discuss all of the side effects and safety issues in relation to the medication. While there is currently no cure for type 2 diabetes and it is progressing, we need to manage it effectively to prevent complications.
The process of teaching patients to manage their diabetes, known as diabetes self-management education, is considered one of the most important parts of the clinical management of diabetes. We aim to involve Bob in self-care behaviours to actively manage his diabetes in order for him to experience few or no episodes of hypoglycemic emergencies. The goals of self-management education are to improve metabolic control, avoid acute and chronic complications, and enhance quality of life. Lifestyle modifications aim to keep Bob's blood glucose levels at normal or near normal levels and prevent or minimize chronic complications of diabetes. As mentioned in Lewis's medical surgical nursing textbook, obesity is the primary risk factor for type 2 diabetes. As Bob is obese, we should advise him on lifestyle changes to manage his weight and educate him about how diet and exercise can affect blood glucose levels. We should encourage him to maintain a healthy diet through an individualized meal plan created in conjunction with a dietitian that encompasses food low in sugar and saturated fat and includes a wide variety of nutritious foods. He can also participate in an exercise program to increase his physical activity. There can be both acute and chronic complications of diabetes mellitus. An example of an acute complication includes diabetic ketoacidosis, or DKA, which is caused by a profound deficiency in insulin. DKA may be seen in patients with type 2 diabetes in the condition of severe illness or stress when the pancreas cannot meet the extra demand for insulin. Because of damage to blood vessels, type 2 diabetes patients are also 4 times more likely to suffer from heart attacks or strokes. Due to microvascular damage to the retina as a result of chronic hyperglycemia, there is also potential for vision loss, which can affect 1 in 6 people. The best approach to the management of diabetic eye disease is to prevent it by maintaining good glycemic control and managing hypertension. Kidney damage is also 3 times more common in people with diabetes. The development of diabetic foot complications is a multifactorial process. They result from a combination of microvascular and macrovascular diseases that place the patient at risk of injury and serious infection that may lead to amputation. Smoking is also harmful to the health of lower extremity blood vessels and increases the risk for amputation. We should therefore advise Bob to wear comfortable fitting shoes to prevent foot ulcers and other complications, and we also need to encourage him to refrain from smoking in order to maintain a healthy lifestyle. Depression, anxiety, and distress occur in more than 30% of people with diabetes. We can therefore provide resources such as diabetes online counselling, Beyond Blue, or Lifeline for patients in order to help them in the management of these issues. We can also encourage patients to become involved in social activities. Early diagnosis, optimal treatment, and effective ongoing support and management reduce the risk of diabetes-related complications. Collaboration with other health professionals such as dietitians or occupational therapists will improve the management of lifestyle changes such as an improved diet and exercise. Bob is encouraged to have annual eye examinations from the ophthalmologist. He should regularly visit his GP for feet examinations and the administration of the flu vaccine, as the possibility for infection could be harmful. He should also have regular urine testing for protein and specific blood tests such as HbA1c and his fasting glucose levels. He should also have his blood pressure and cholesterol levels checked just to make sure that there's no complications with anything.
According to national safety and quality healthcare standards, it is necessary to respond to Bob's deteriorations in the hospital setting. To understand the Bob's condition and to identify the deterioration, it is very important to hand over Bob to the next nursing shift via bedside handover and through